morning. My name is Teresa Rovegno. I'm the nurse manager of the 8th floor inpatient medicine unit at Stanford Health. Today, I'm going to be speaking with you about implementing the National Institute of Health Stroke Scale, or NIHSS, for nursing use. Stanford Health is a freestanding community healthcare organization that features a 305-bed inpatient hospital and multiple ambulatory care areas. The organization is designated as Plaintree Gold, is recognized by Magnet for excellence in nursing care, and holds a Joint Commission certification as a primary stroke center. The NIH Stroke Scale is an assessment tool that numerically scores a stroke patient's symptoms by assessing neurological deficits. The lower the score, the better the prognosis. The reason for implementing the NIH Stroke Scale was in response from a redesignation visit from Joint Commission to maintain our primary stroke center designation. During the survey visit, it was noted that the physicians are currently using the NIH Stroke Scale. However, the nurses are using a homegrown stroke assessment tool. There's no consistency between the two assessment tools. The final finding of the redesignation visit was that all nursing stroke assessments must be done using the NIH Stroke Scale by nurses who are certified in its use. An action plan was put into place. Every nurse from the emergency department, intensive care unit, and medicine units would be required to receive online education and receive certification through Apex Innovations before June 12, 2018. The policy and procedures for care of the stroke patients was updated to reflect new Joint Commission standards of care. Chart audits are being completed to monitor for compliance with regulatory requirements that the NIH Stroke Scale is being done timely, accurately, and reliably. Stroke is the leading cause of disability and the fifth leading cause of death in America today. Time is a critical factor in stroke treatment and outcomes. The faster new or worsening neurological deficits are accurately noted, the sooner treatment decisions can be made and more brain is saved. The use of the NIH Stroke Scale provides a common language for nurses and physicians, facilitating better communication within the healthcare team for better patient outcomes. The NIH Stroke Scale accurately assesses the type and location of stroke, along with predicting the level of recovery. The implications for Stanford Health if the NIH stroke scale is not implemented are both immediate and potential. The immediate consequence would be the loss of the primary stroke center designation. The potential implications include affecting the goal of the organization's current strategic plan. One of the goals is to grow the neuroscience service line. The objective, or one of the objectives to reach the goal, is achieving the designation of the Comprehensive Stroke Center by Joint Commission. Stanford Health is in a healthcare-rich geographical area. The market share that Stanford competes with is Yale, Columbia, New York Presbyterian. All have mature, accredited stroke programs. Healthcare clients have many choices where to seek treatment, and healthcare systems advertise their specialty programs. There are billboards up and down the I-95 corridor between the Yale New Haven network and the Columbia network. The financial impact is estimated to be a net revenue loss of $800,000 yearly. The loss of revenue would come from the emergency department, the inpatient rehabilitation unit, and outpatient services. Nursing using the NIH stroke scale is currently being implemented in response to a regulatory finding. The NIH stroke scale is an evidence-based assessment tool. It allows for caregivers to speak the same language. When really looking at our homegrown nursing tool assessment and the NIH assessment side by side, it was immediately apparent that the two stroke scales and assessment tools had little commonality, and the physicians and nurses were comparing apples and oranges. The pressure to assess stroke symptoms thoroughly so treatment decisions can be made both correctly and quickly is magnified, second to the importance of time from last known well to treatment. Effective communication between the care team advances the quality of not only the assessment, but the treatment of new or worsening stroke deficits. Although nursing does not make treatment decisions, it is imperative that the NIH stroke scale assessments are used. NIH stroke scale assessments can identify subtle changes or with noticeable changes in condition indicate a shift from an ischemic to a hemorrhagic stroke or an expansion of the ischemic stroke. Joint Commission coming in for a regulatory visit is always stressful for an organization. However, the stroke program core team has always viewed the visits as an opportunity to learn and improve the quality of care our patients receive. The designation of a disease-specific specialty is really an obligation to continually look at our practice and improve the quality of our program along with that care that the patients receive. The risks associated with the implementation of the NIH stroke scale is that the tool is complicated. It takes time to do, especially when the practitioner is unfamiliar with it. The two biggest risks are the staff isn't comfortable with doing the assessment. It is subjective. Only the patient's first response counts, or the assessment can be skewed. The staff has only had online training up to this point and are asking for hands-on training. The other risk with this is the staff is questioning the value of the NIH stroke scale in compared to the tool they are using, the tool they have been using. One of the main roles of the nurse leader is to be a change agent and champion innovation. The nurse leader creates and maintains a culture that accepts change by communicating the need for the intervention or innovation, listens to staff members who are using the innovation, and works to understand the barriers that the staff members are seeing. In this case, the main barriers are lack of confidence using the NIH stroke scale tool and not seeing the value of it. Communication about the value of the tool, both for the staff member and for the patient, is ongoing. Tapping into the interprofessional team, the neurohospitalists have agreed to help with both communicating the value of the tool by speaking at safety huddles on the medicine unit, and the lack of confidence by providing some hands-on training by holding several in-services in the emergency department, the ICU, and the medicine units. The in-services won't affect the budget. They'll be done on several shifts for 2 or 3 weeks to try to capture everyone who's on shift. Ongoing audits have been started to evaluate our practice as we have started using the NIH stroke scale to ensure that we are compliant. But more than that, the NIH stroke scale is a complex tool and it'll take some time and the additional education to ensure all nurses are competent in using the tool. A work environment that is transparent so the nurses know where the opportunities lie, and providing them with tools to correct the barriers or the problems they see in a non-punitive, non-judgmental manner. Any new innovation that is put into practice is an opportunity for learning. Mistakes and errors can happen with any new practice. In fact, they can happen with an old practice. They must be addressed compassionately in real time for maximum impact to create a culture where learning and taking risks thrive. As a nurse leader, it is my role to ensure regulatory compliance. While doing this, it is also important in my practice to seek out staff feedback. When staff know they are being heard, they bring forward issues that a leader may never think of. Being open with ideas and looking at the process behind errors as opportunities to provide improved quality and safety of care helps to maintain a unit culture that will accept change and look for innovative practices. Christ is the ultimate change agent, leading with compassion and conviction. Modeling my nurse leader practice from Christ's inspiration is as Hebrews 11:1 says, "Now faith is the assurance of things hoped for, the conviction of things not seen."